Is it important to assess cardiovascular risk for my patients? Extremely important, for two reasons. Number one, estimation of the risk makes you properly estimate the problem you are facing. It should be very accurate so as not to make the same fault as the pilot of Titanic did when he assumed that the iceberg is only a flake of ice. And then when he hit it, he made a major catastrophe. So do not underestimate, do not overestimate. As we see, the risk factors is like this. This is what appears to you, but actually the actual risk is very serious. And this is, of course, the catastrophe that might happen if you do not estimate the risk properly. Number two, estimation of the cardiovascular risk helps you to persuade the patient that he is having a serious problem, so that he is compliant to medications, compliant to physical exercise, dietary changes that you are going to make. In 2021, the ESC guidelines on cardiovascular disease prevention and clinical practice made it somewhat clear. Instead of being blurred, it's somewhat clear. It classified patients as 4 categories. Apparently healthy persons, and I think that this is the most serious problem, because I don't have any problem assessing the risk of a patient with having established cardiovascular disease. He already had a stroke. He already had a myocardial infarction. He already has an amputated limb. So we know by default that this patient is having serious cardiovascular disease. Patients with diabetes, we know that all diabetics have how many folds of higher cardiovascular disease than non-diabetics? 4-fold, 2 to 4 folds actually. So if a patient is diabetic, by default he's having high cardiovascular risk. And a patient with specific risk factors like CKD and familial hyperlipidemia, we know that these patients already have high or very high risk. So I don't have any problem dealing with patients with atherosclerotic cardiovascular disease, type 2 diabetes or CKD and familial hyperlipidemia. The problem is assessing apparently healthy persons. That's why the term is apparently healthy. He's not healthy, he's apparently healthy. Okay. And the definition of apparently healthy, that the patient who does not have the other risk factors like atherosclerotic cardiovascular disease, diabetes, CKD, or familial hyperlipidemia. So whenever we have a patient that do not have these items, he is apparently healthy. Let's give an example. Everyday's case. 55 years old, stressful job, limited physical activity, no prior current health problem, current cigarette smoking, blood pressure 120/70, perfect, fasting blood sugar 85, A1C 5.1, creatinine 0.7, he's somewhat obese, 31 body mass index, with LDL 155 and non-HDL 220, triglycerides 145. Is this a high-risk patient? I don't think so. This is every patient that comes to your clinic every day. How do you deal with him? Actually nothing. You will tell him, okay, you need to lose weight and to decrease your LDL, stop smoking, and that's all. Yes? Is he risky? He is risky. Okay, let's see. First, in 2016, the European Society of Cardiology Prevention guidelines invented a score, which is the systemic coronary risk score, giving 10 years risk of cardiovascular death, but it didn't mention the risk of myocardial infarction and stroke. That's why they invented score 2, which is a modification of the score, 10-year risk of fatal and non-fatal myocardial infarction in the patient between 40 and 69 years old. So, apparently healthy persons, stop smoking, lifestyle modifications, systolic blood pressure less than 160, and then classified according to age, less than 50, 50 to 70, and more than 70, and then you should estimate the cardiovascular risk. How do I estimate the cardiovascular risk? First of all, we should know where we are. We are in Egypt. Egypt's classified according to cardiovascular mortality like high risk, very high risk countries in Europe. So, first of all, if I'm living in Egypt, I'm choosing the chart of very high risk countries. So, low risk, moderate risk, high risk, very high risk, every category has a chart. So first of all, where am I living? I'm living in Egypt. So I would choose which chart? The very high risk chart. And then, this is the chart. It's somewhat complex, as you see. Systolic blood pressure, smoking, non-smoking, male, female, non-HDL cholesterol, and age. These are the 5 factors that apply to get the cardiovascular risk. And then, this is according to age. It's a very long chart. Let's see our patient. If we have a patient who's 55 years old, as we said, he will have cardiovascular risk of 17. 17? This is high cardiovascular risk. How come this patient is 55, smoker, LDL is high, and that's all? Is he high risk? He is high risk. Let's see. Very high risk cardiovascular disease is between, our patient lies in this category, between 50 and 70, and he's more than 10 years cardiovascular risk, more than 10, so he is very high risk. How many patients like this we face every day? Many. And we miss them because we do not calculate the risk. We say it's okay. He's young, having only mild hyperlipidemia, and he's a smoker, and he's having body mass index, high body mass index, as I have myself. So, it's a common mistake. Does age matter? Does it differ? The relationship between classical risk factors, like lipids and blood pressure, with cardiovascular disease attenuates with age. So the older the patient, the less the effect of these risk factors on the cardiovascular outcome. Number 2, that cardiovascular-free survival dissociates from the overall progressively with increasing age, overall survival, progressively with increasing age because the risk of non-cardiovascular mortality. So in older age, non-cardiovascular mortality is higher than cardiovascular mortality. That's why the cardiovascular risk, as age increases, is somewhat attenuated. That's why they invented a score. We said that from 40 to 69, we use the score of score 2. And if we apply to a patient who is 70 years or older, we apply another score which is score 2 OP, older population. So we have a score for below 70 and another score for above 70. And this is the effect of age. As we get older, the category of high risk, which is in red here, the very high risk category, is decreasing, not increasing. This is very complex. And the table of cardiovascular risk of that score is extremely complex. So if I advise you to use it every day, you tell me I don't have that much time. How many patients do I see every day? A lot of patients. It's very difficult to apply and to check if the age, male, female, smoker, non-smoker, HDL, this is very difficult. I cannot do this. So we were waiting for something brilliant, for an idea that makes it easy for assessment. Till the European Society of Cardiology got us a digital solution for this. Very easy. An application you can download on your mobile phone. It's available for free on the App Store, and you can get it very easily. The ESC cardiovascular risk. This is the display of the application. Now, first of all, it asks you if you want to assess 10-year risk or lifetime risk. And if we need to assess the 10-year risk, which is the most common, it will give you this page which says score 2 for people less than 70 years, okay? And score 2 OP, which is more than 70 years, score 2 diabetes for diabetics, SMART for patients with established cardiovascular risk factors, established cardiovascular disease, and atherosclerotic cardiovascular disease. This is an American scoring system put for the Americans. And then it helps you find the region. Do you know that your country is Europe low risk, intermediate risk, high risk, very high risk region? I don't know the information. Okay, search by the country. If you search by the country, you find that Egypt is your selected category. In Egypt, selected category is Europe very high risk. So it's easy. You don't have to even remember this. You go to the application, you put that I'm in Egypt, and the age, and some other parameters, and we will go on together. This patient is a male patient, 55 years old, current smoking, systolic blood pressure 120, total cholesterol 210, HDL 27, LDL cholesterol 155, then calculate the risk. These are the parameters. He revises the parameters again, and then 17%. And according to age, it's very high risk, very easy, in a second, at your mobile phone. Simple, yes? I myself use it on daily basis. It's really magic. Whenever the patient tells you, I'm okay, I don't feel that I'll have any problem, just show him this is your risk. Come here, you are in the red area, so you are at risk. Yes? And then, it's not only this. Stop and think. And you should follow all the risk modifiers, because they are accused other factors like the calcium scoring, the carotid ultrasound. If you suspect that the patient is high risk and you do not find data by the risk score, you can add other factors like calcium scoring and carotid ultrasound, checking for the carotid intramedia thickness. So, if the patient is mild risk or moderate risk in all the categories, it's okay. You can keep the blood pressure at 140 and the LDL below 100 is okay. But what if the patient is high risk? Below 55 and above 70, you should keep the LDL levels lower, keep the blood pressure low. So this is the importance of estimating the cardiovascular risk, is selecting or picking up the patients who need more care, who need more persistent to control the risk factors. Okay? Then we come to the patient with established cardiovascular disease. Established cardiovascular disease means very high risk. So imagine that our same patient had myocardial infarction 10 years ago, and let's put him on the scoring system on the app. And now we will use the SMART scoring system. First of all, you should stop smoking, lifestyle modification, LDL less than 70, systolic blood pressure less than 130, if tolerated, antithrombotic therapy, and then assess the residual risk. Here, we'll use the SMART risk score, male patient, 55 years old, 10 years from the cardiovascular event, current smoking, having coronary artery disease because he had a myocardial infarction and he's on antithrombotic therapy, of course. Systolic blood pressure is 120, creatinine 1, high sensitivity C-reactive protein is normal, total cholesterol 210, the same data as before, and HDL is 33, calculate he's having cardiovascular risk of 15%, which is also high. So this lets you know among patients with high risk who is having higher risk than others. This is important also. Okay, let's imagine that the same patient had diabetes 25 years ago. We know that diabetes increases the fold by 4 times. Increases the risk of cardiovascular disease. So in the past, 2021, he used to to classify patients with diabetes or patients with diabetes with established cardiovascular disease and without established cardiovascular disease. So diabetes with established cardiovascular disease is of course of higher risk. Diabetes without cardiovascular disease is of lower risk, and these were the targets. Till 2023, in August, these were the guidelines for management of cardiovascular disease in patients with diabetics, specifically for diabetics, and they put ranges for diabetes and pre-diabetes, and then they classify patients into very high risk, which is the patient with diabetic, clinically established cardiovascular disease, or severe target organ damage, or 10-year cardiovascular risk more than 20, using the SCORE2 diabetes score, which is also available on the app. And then high cardiovascular risk, diabetes not fulfilling the high risk criteria, and the risk is 10 to 20%, and then the moderate and low risk, and that's all. So patients with atherosclerotic or severe target organ damage, yes, so they are very high risk. No, you do the scoring, more than 20, they are very high risk, 10 to 20, high risk, 5 to 10, moderate risk, and less than 5 is low risk. And there is no patient with diabetes, I think, will have score less than 5. So let's see the SCORE2 diabetes also. Male patient, same patient having diabetes 25 years ago. Male patients, 55 years, age at diabetes diagnosis was 40, current smoking, systolic blood pressure 120, total cholesterol 210, the same data. Hemoglobin A1C 8, eGFR 80, and then calculate and you find the risk is 26.8, which is also very high risk. So, finally, the score, estimating the cardiovascular risk by this app is extremely useful, extremely simple. You can do it at your desk every day, very simply. All you need to do is to be positive, patient, and persistent. Thank you very much.